This is a time-lapse of human dermal cells rapidly proliferating to close a structural gap. In recent clinical trials, salmon-derived DNA biopolymers have achieved measurable structural repair like this, including a nearly 60% reduction in periorbital wrinkles over 12 weeks. The macroscopic evidence is equally distinct. In trials treating diabetic foot ulcers, these DNA-based treatments achieved complete wound closure in over 37% of patients, nearly doubling the success rate of the placebo group. Yet as clinical adoption surges, a foundational error has emerged in aesthetic and regenerative practices: the frequent conflation of polynucleotides, or PN, and polydeoxyribonucleotides, PDRN, as identical therapeutics. Both are extracted from the same source material and share a comparable deoxyribonucleic acid backbone. However, treating these two compounds as interchangeable leads directly to clinical misapplication and suboptimal outcomes for the patient. The defining physical variable that dictates their biological behavior in human tissue is their polymer chain length and, consequently, their molecular weight. This scale maps molecular weight. The definitive boundary separating these two compounds is the Marquez polynucleotide cutoff, established exactly at 1500 kilodaltons. Below 1500 kilodaltons, the material operates as a rapid pharmacological agent. Above it, it acts as a highly viscous structural scaffold. Mastering this specific molecular weight division is mandatory for practitioners to accurately match the correct regenerative tool to specific tissue defects. To understand how chain length drives these effects, we first look at the source material. These biopolymers are extracted from the spermatozoa of chum salmon and rainbow trout, specifically harvested during their spawning phase, when cellular energy is entirely redirected toward producing densely packed DNA. Salmon spermatozoa is utilized because it exhibits over 90% homology with human protein coding sequences. This extreme genetic proximity to human tissue ensures a high degree of biocompatibility. The raw material undergoes a rigorous purification protocol, concluding with moist heat sterilization in an autoclave, precisely at 121 degrees Celsius. This extreme thermal processing is critical. It completely inactivates proteins and lipids, achieving greater than 95% DNA purity. The result is an immune-privileged substance. Returning to the Marquez cutoff, we can now strictly define PDRN. These are short, linear, single-stranded chains falling below 1500 kilodaltons. A standard PDRN chain comprises just 10 to 30 nucleotides. By contrast, PN is composed of significantly longer, heavier DNA fragments. To be classified as PN, the molecular weight must measure 1500 kilodaltons or greater. While classic PDRN hovers around an average of 132 kilodaltons, recent pharmaceutical studies have expanded the observed range of these extracts from fragments as small as 1 kilodalton to as large as 10,000. The Marquez cutoff provides the clinical dividing line within this wide spectrum. Because the intensive heat purification process virtually eliminates allergenic variables like proteins, molecular weight remains the single independent variable driving distinct clinical responses in human tissue. PDRN's shorter chain length and lower molecular weight allow for high tissue penetratability. Once injected, it is rapidly broken down by endogenous nucleases. This cellular model shows PDRN's primary mechanism. The compound degrades into adenosine nucleosides, docking directly into the A2A receptor subtype on fibroblasts. This engagement initiates an intracellular cascade, stimulating GS protein and forcing the release of CAMP. This specific signal transduction chemically commands the cell to suppress pro-inflammatory pathways like nuclear factor kappa beta, while simultaneously downregulating matrix metalloproteinase 1, an enzyme responsible for degrading collagen. Concurrently, the pathway upregulates VEGF to promote the growth of new blood vessels, and COL1A1, an early marker that triggers osteoblast differentiation and direct collagen synthesis. The second major mechanism of PDRN is its activation of the nucleotide salvage pathway. This side-by-side comparison demonstrates the energy mechanics of DNA synthesis. Generating new DNA from scratch, the de novo pathway, requires an immense amount of ATP energy. The salvage pathway bypasses this by recycling already released bases and nucleosides. This energy-efficient route is critical for treating damaged, hypoxic tissues lacking energy for standard synthesis. Reparative cells hydrolyze the PDRN fragments, slotting them directly into the damaged host DNA, rapidly restoring its capacity to replicate. PDRN operates with a very rapid half-life of roughly 3 hours. It does not linger in the tissue. PDRN is an active, targeted pharmacological tool. It does not passively fill empty dermal space. It chemically commands cellular regeneration and rapidly exits the system. By contrast, as molecular weights exceed 1,500 kilodaltons, the compound transitions from a liquid preparation into a complex polymer structure. This is PN. This simulation visualizes the biophysics of PN. The longer, heavier nucleotide chains fold and tangle upon themselves, forming a highly porous, three-dimensional mesh framework. This creates high viscoelasticity. It allows PNN to act as a physical, structural support agent within the dermal layer, operating in a manner mechanically similar to hyaluronic acid. The mesh is highly hydrophilic. The tangles in the structure trap water content, allowing it to restore skin hydration and improve tissue volume by creating a dense hydrogel. As we see in this diagram, the degradation kinetics are drastically different from PDRN. Endogenous nucleases have highly restricted access to this tightly folded matrix, breaking it down slowly from the outside. Instead of a rapid chemical spike, PNN provides prolonged structural scaffolding and sustained metabolic stimulation of local fibroblasts. PNN's primary value lies in its physical properties, establishing a durable, hydrated environment that facilitates broad-scale, long-term tissue regeneration. This matrix maps the actionable clinical decisions derived from these biological mechanisms. Clinicians prescribe PN for broad structural support, early laxity correction, and full-face anti-aging. PDRN is prescribed for precise, active repair, targeting acne scars, striae, diabetic ulcers, and acute erythema. To maximize these effects, combination protocols are becoming the standard of care. Over 55% of surveyed clinical practitioners report combining PN with hyaluronic acid. The mechanisms cooperate perfectly. Hyaluronic acid provides immediate hydration and physical plumping, giving polynucleotides time to initiate progressive cellular regenerative processes. On this 12-week timeline, the standard PN dosing protocol involves injecting 2 cc every 3 to 4 weeks for 3 to 4 sessions. Setting patient expectations is critical. Immediate hydration effects appear within days, but true structural improvements develop slowly over the cycle. The absolute peak efficacy of the treatment does not occur until approximately 3 months post-treatment, when the new collagen maturation fully progresses. Successful outcomes depend entirely on adhering to these delayed biological timelines, rather than treating the biopolymers like instant volumizing fillers. Ideal candidates for these protocols are patients seeking progressive texture improvement, or those requiring treatment in delicate periocular areas where traditional volumizing fillers are unsuitable. Mandatory contraindications include pregnancy, breastfeeding, active localized infections, and severe inflammatory skin conditions. Practitioners must also account for fish allergies. While extreme 121-degree thermal purification inactivates the proteins that trigger immune responses, highly susceptible patients still require prior patch testing to ensure safety. Following the initial cycle, patients must enter a maintenance phase. Single sessions are required every 6 to 12 months to prevent regression in fibroblast activity and maintain collagen production. The field continues to evolve. The exact downstream regulatory mechanisms of PDRN require deeper clinical investigation, and a current lack of universal manufacturing standardization can lead to product variability between brands. As pharmaceutical platforms refine extraction processes, practitioners who master this molecular weight divide will be equipped to apply these biological tools with clinical precision.